implicit bias, it does play a role, because as you can see, I'm a Black woman, so I can't hide that. So anytime I'm out and about in the community, there are things I think that happen to me simply because I'm a Black woman, and I would be, naive to think that those same things don't happen in the hospital.
Welcome to the Unapparent Podcast, the place that delivers deeply human stories about the unapparent truths of parenting. My name is Katia Reguero Lindor, and I am your host. Join us as we debunk myths surrounding parenthood and provide an empathetic, judgment-free space for parents and parents to be. We hope you enjoy the show. Hello, everyone. Welcome to another episode of the Unapparent Podcast. Today's guest is Dr. Dawnette Lewis. She is an unwavering force in the field of maternal-fetal medicine. Hi, Dawnette. Thank you so much for being here today. If you don't mind introducing yourself professionally and personally to the extent you feel comfortable.
Hi, Katia, and thank you for having me today on your podcast. My name is Dr. Dawnette Lewis, and I am a maternal fetal medicine specialist, which is a high-risk obstetrician. I currently work in the Northwell Health System and direct a maternal fetal medicine division at North Shore University Hospital. Professionally, personally, I am the youngest of 6 children, originally from Jamaica in the West Indies, and I am the mother of 2 children.
Thank you. So your children are 9 and 7, I believe?
Yes, they're 9 and 7 years old. I have a boy. My oldest is a boy, Logan, who's 9 years old, and my youngest is Ella, and she's 7 years old.
Okay, well, I'm still in the trenches of little kid phase, but how was your experience with pregnancy, labor, little kids up until now, and how has that impacted your career, as an obstetrician?
Sure. So when I decided to have children, I was in that advanced maternal age category, so over 35. And I'm a high-risk pregnancy specialist, so I can't turn my brain off. So I, was always worried, you know, what could potentially happen. I think like a lot of women, once you're over 35, your fertility decreases. So I required IVF in order to get pregnant. And I know it might seem intuitive, but even though I'm in the field of OB, you're just working and you don't really think about, what that means to, start having babies later on in life. And once I got pregnant, I wanted to deliver at a hospital where I knew that, they had seen everything. And I know a lot of times patients talk about their, first meal in the hospital where they have a lobster or champagne, and I wasn't really concerned about that. I wanted to make sure that if I was at a hospital that it was a high level hospital that was pretty skilled since I was an older mom having children and anything could happen. With my first pregnancy with Logan, it was essentially uncomplicated. I didn't have any issues in pregnancy with high blood pressure, with gestational diabetes, any issues worrying about a short cervix or preterm labor. And I worked up until my delivery. So I finished work on Friday, and on a Sunday I had an induction, and I didn't deliver my baby on and Tuesday I was still pregnant. So my partner and I, we just, who's also an OBGYN, he and I told the obstetricians, we've been at it for 2 days and, I'm not delivering. So I ended up with an uneventful cesarean delivery. And I had an uneventful postpartum period. And when I saw my son, I wondered to myself, why did I take so long to have a baby? Because I fell in love instantly. And I know they talk about how to hold the baby in the hospital and what not to do, but I had that baby right down, my gown, the entire time because I didn't want to let him go. My second pregnancy with Ella was also very uncomplicated. It was the delivery that became pretty complicated. So I ended up having what's called a placenta accreta, which is an adherent placenta that grows into the uterus, and so it can't be separated, and it incurs a lot of bleeding, a lot of hemorrhage, and so I ended up having being intubated, having a hysterectomy after my second delivery, and I remember, telling Wayne, my partner, because I felt at the time of the C-section that my placenta was not separating. And he said to me, "You could feel that." And I said yes. And I remember turning to the anesthesia resident because I remember he was like a young Nigerian resident, and we had been talking prior to going into the operating room. And I remember turning to him and saying, "I think you're going to need another IV," because I knew I was bleeding a lot. And the doctors, they were trying everything to stop the bleeding. And then the surgeon, who was also a high-risk specialist, she came up to the head of the table and she said, "We've tried everything and, the bleeding is going." And I said, "Listen, I have two healthy children. If I, sacrifice my uterus, that's completely fine." And so things happened pretty quickly. And I ended up, when I woke up, I was in the ICU. And I remember that my daughter had been delivered at like 9:46 in the morning. And when I opened my eyes, it was 12:30. And I said to myself, "Oh, that was a really quick surgery." And I know how long those surgeries are and how complicated they can be. And then I realized that it was 12:46 the next day. So I had
Oh.
lost like an entire day because I had been intubated and admitted to the ICU. And I knew I wanted to get out of the ICU as quickly as possible.
Mm.
But I know when I reflected on it, I just felt that I had chosen the right place to deliver. I didn't expect this complication because of where my placenta was located. It was in the back of the uterus. Normally, this complication with someone who's had a prior cesarean delivery, the placenta is in the front of the uterus. So the fact that mine was in the back of the uterine wall, it was like one in a million that this would happen. So it was completely, unexpected. But, I remember saying to my family and, my friends that I was just, very grateful for the staff around me and the people, around me. And I felt like, I had this gift, like, this new lease on life. And I felt, I wanted to, make that time meaningful, both for my children and for my career, and which is, how I ended up in the position where I am now. Because, even though it's wonderful every day to deliver a baby, and to give birth, like that interaction is one-on-one. I felt like I had a larger mission to try to, impact, maternal health and maternal mortality on a larger scale in the position that I currently hold.
Yeah, that's an amazing, personal story, and then how that has influenced, I'm sure, your professional life. It's pretty incredible, and I'm so happy that you were able to get the care that you needed and deserved to have, right? And from your bio, I know that you were a big advocate for mothers, especially for Black mothers, and their babies. And we know that in this country, data shows that maternal mortality rate for Black women between the ages of 30 and 34 is significantly higher than the rate for white women. So, what are your thoughts surrounding this specific topic? And do you think the medical community has mobilized in order to prevent some of this implicit bias risk that is seen in mothers and their babies?
Thank you for that question. I think it's not just moms in that specific age group. I think in general, when you look at Black birthing moms compared to white moms, and that's the traditional comparison, that we have in the literature, we know that Black women are at a much higher, 2 to 3 times the rate of dying in pregnancy comparing to their white counterparts. And the reasons I think are multifactorial. And I think that it has to take many, many different efforts in order to combat this. Implicit bias, it does play a role because as you can see, I'm a Black woman, so I can't hide that. So anytime I'm out and about in the community, there are things I think that happen to me simply because I'm a Black woman, and I would be naive to think that those same things don't happen in the hospital, that people don't have these, unconscious bias and implicit bias that unconsciously drive how Black women are treated and how Black women are perceived in the hospital. And I know that there are many efforts across the country addressing implicit bias, not just in maternal health, but also in healthcare in general. Um, and, I think that one of the things that we've noticed here in our health system is that when you make the issue specific to the area that you're working, I think it resonates more with someone. So it's difficult, I think, for me to talk about disparities in dermatology when they might exist in OB. But when you talk about maternal mortality and how the things that we do in the hospital and how we treat patients can contribute to that, I think it really hits home, and it has people look internally to see what can I do to change things differently. And I think it's not just on an individual level, it's also on a system level. So we
Mm.
have to develop systems that sometimes take out our individual biases so that everyone gets the same treatment, and that that treatment is equitable.
Right. Yes. And as you say, it's, I think, all across the board when it comes to, you know, women's health, right? And it's something that I think we're all aware of at this point, that we're decades behind in women's health. But when we talk about specifically, I guess, Black women and women of color, we see the disparity. So I think these are questions that merit, like, we need to kind of dive deeper, right, and figure out why this is happening. And once we know why, then fix it, as you say, on a systemic level. Um, and in that same vein, we also know that in this country, at least in the U.S., there's a quite high percentage of C-sections. Even though I think globally we do see that trend, my understanding is that in the U.S., it's one of the highest percentages. Is this something that you can discuss with us, that you've noticed on your expertise, what you think about this?
Sure, no, absolutely. One of the things, I think I'm also learning every day, and we participate in a birth equity project with New York State. And I remember one of the slides in that initial presentation that, the 70 plus birthing hospitals across New York State had, and it was a sentiment that Black women felt like they were always being offered a cesarean delivery. And it made me think, and I was like, is that really true? And when we looked at our data in our health system, we saw that patients, generally, if you have complications during the pregnancy, medical conditions like high blood pressure, diabetes, those conditions tend to complicate pregnancy and can lead to an earlier delivery, which sometimes necessitate a cesarean delivery. But we also wanted to concentrate on patients that we thought were low risk, that didn't have any medical complications. And we saw that the cesarean delivery rate, it was higher for our Black birthing patients. It was significantly higher. And then that led us to then say, why is that? So we don't completely understand why. And we're going to each individual patient chart in our system to abstract as much information as we can to look at, what time the patient got into hospital, when were they admitted, what kind of interventions or what did or didn't happen, to see if we can learn more from that, because we're still learning. And there are many hospitals across the country that are undertaking an initiative called the Nulliparous Term Singleton Vertex Initiative, NTSV for short. And what that is that we're aiming to decrease the cesarean rate for first-time moms, because we know that a cesarean delivery increases your rate of maternal morbidity, meaning needing an admission to the ICU, needing a blood transfusion, having a risk for infection, and having a risk for having a hysterectomy. And so across all the hospitals, where I work, what we're trying to do is to look at all the indications for cesarean deliveries, and we're looking at the rates of the physicians in the hospital and physicians that have high rates. The leadership in the OBGYN department meets with those individual physicians to talk to them about how can they decrease the risk of the cesarean delivery. And I'm happy to say with this initiative in our health system, by doing that, that we've managed to decrease our overall cesarean delivery rate by 2%. And that's within a year and a half. And so we're going to continue to do this to educate patients more about what questions you should ask your obstetrician, because I truly believe that when you enter prenatal care, whether you have a midwife as your care provider, you have an OB, a family medicine physician, to start having a dialogue early in pregnancy about expectations for labor and delivery, what that might look like. And I also encourage pregnant patients or anyone capable of giving birth to take a Lamaze class. Many hospitals have tours. I know now that we're out of COVID, that those tours have restarted where you can go to the hospital that you plan on delivering and you can see what the hospital is like and what's available to you, and you can ask as many questions as you'd like. So I think those things are very important because when you come to the hospital, I think it's difficult because it's a short time to really um, connect with the people because the person in the hospital delivering you may not be the person that you saw most of the time that you're having your prenatal care. And so that's why I encourage a lot of dialogue and a lot of questions during your pregnancy about what to expect when you're there, and to bring family members, people who you think are allies. And I used to always tell my patients, sometimes you forget to ask questions when you're in the office. When you get home, just write them down and bring them back at the next visit so that we can discuss, so that we can prepare. Because in the end, we want a healthy mom and a healthy baby.
As you said, asking questions is such an important part of that prenatal care and that relationship with your healthcare provider, right? You might be aware that I had 2 home births with both my daughters, and part of the reason why I chose this birth plan, right, was because of some of the issues we've discussed. And furthermore, that one-on-one relationship that you get with midwives. And I think there's this misconception about the kind of care midwives provide. It's actually comprehensive, prenatal care, and they educate you. They're available 24/7 to answer all of your questions, and they monitor the pregnancy very, very closely. And that was the kind of care I was seeking. And that's not to say that you don't get that with traditional, OBGYNs. I'm sure they exist. They're out there. It just seemed to be where what I found in that time in my life when I was choosing it was COVID with my first of all. So that was a big influence as well, having that care that came to you, that your partner could be part of. They could see the sonograms at home because you weren't allowed to go into the sonogram rooms at the time with COVID. You understand that crazy time in our lives. But yeah, so that was one of the reasons, or some of the reasons that influenced my decision. But I think that's even when I have friends who ask me for advice and they go the traditional route with OBs in the hospital, I say just ask as many questions as you can. And for me, I guess knowing that there's so many things you don't know going into it, right? So you maybe don't know the right questions to ask. I said always at least know your rights and have, be clear with what you can and deserve to expect with your care, and to have, the kind of birth you hope for. Just advocate for yourself, right? And obviously, in order to be a candidate of a home birth, you need to be very low risk, have no kind of health complications prior. Your baby needs to be healthy, and midwives know, because they're monitoring so closely, if any complications arise, you no longer are a candidate for home birth, and you need to, go to the hospital and seek care from high risk doctors and all of that. So it was a very informed decision in my case, right? But I think what you said about asking questions and taking a tour and having that one-on-one relationship with your healthcare providers and knowing what you want, knowing what to expect, and just being informed, it's so important for that prenatal period, and that will largely inform, what maybe your labor and postpartum might look like.
Yeah, no, I completely agree, and I do understand how COVID was such a stressful time because we some hospitals didn't allow support persons in because oftentimes we didn't know what their status was, or people didn't
Mm-hmm.
disclose what their status was. And similarly with ultrasounds, we had arranged for iPads and things in the room so a spouse could may not, if they weren't in the room, that they could be in a parking lot and connected. But that definitely does not take the place of someone at your side supporting you. So I certainly understand, why you made that personal decision to deliver at home. And I have to say, midwives, they're fantastic because when I was a resident, I trained with midwives and they've taught me a lot about labor and delivery and the birthing experience. So I think of labor and, labor obstetrics as a big tent, and everyone who, is there to, take care of moms and, have healthy moms and healthy babies. They're all, that's what we're for. Uh, but there's limited data that we have about looking at birth outcomes based on the setting where someone delivers, whether they're at home birth with a lay midwife or a trained midwife, compared to someone who delivers in a hospital with a trained midwife. And we know that people who deliver at home, there is a risk for increased perinatal morbidity and mortality when you deliver at home. But Katia, I think you hit on a great point when you said that you had a conversation with your midwife. And I think it's really important that if people are going to deliver at home, that they know that, that they're low risk, as you described, that there aren't any complications with the mom and there aren't any complications with the baby. And I think that's really important. And I also think that it's important to have a backup plan,
Mm-hmm.
when this is happening, and for that midwife to have an affiliation with a physician or with
Mm-hmm.
a hospital so that if there's anything wrong, because one of the things that, I think it's very important to know your risk before you attempt a delivery at home. And we make a distinction between patients being high risk and low risk. And knowing that you have no serious medical conditions, knowing that your baby's okay. Often we screen for something called Group B strep in the third trimester, knowing that you're negative and that you're not going to need antibiotics in labor, which helps to take care of the baby. I think those are really important information to know before attempting a delivery at home. And I think it's also important that the midwife that's attending your delivery has an affiliation with an OBGYN because from my, experience in labor and delivery, we know that deliveries can go from low risk to high risk in an instant, that things can change. And so having that backup, where if you need to go to a hospital quickly, if there's something that's happening, that those kind of plans are established. But we know from the data that we have, even though it's limited, that deliveries at home tend to be more complicated and have increased perinatal risks than deliveries outside of the hospital. So I say that we need more data. Certainly, there are other countries where we know deliveries happen at home with midwives, but we don't have that kind of system here in the United States, and we definitely need more data. And we need to make sure that we're the patients who are delivering at home, that they're truly low risk, and that there's always a plan in place that if there's an additional or a higher level of care, that can be gotten quickly. And I do understand, listening to your experience and why you chose to deliver at home because I have my niece who's in her 20s and she and her friends, they're either, getting married or they're partnered and they're thinking about starting a family. And even her friends who are pregnant, listening to all the statistics. she says that they are afraid to come to the hospital because they're worried, what's going to happen to me, and they want to know if they're going to be safe in the hospital. And I think part of my job, when patients or anyone asks me this question, is to know that, we understand, that there's a crisis and we understand the statistics. But what we don't want to happen is for people to be afraid to come because we know that, we are doing the best that we can to combat, these statistics and to improve the care of moms in our healthcare system.
Hmm. Yeah, and that's so important, right? That the 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 mother and babies are the priority, that their well-being, their autonomy, and that the baby's well-being is what's the utmost priority, right? And I think that's where the disconnect is, where the past, few decades, maybe women have increasingly felt that they aren't having respected births in hospital settings, right? And that's not every hospital, that's not with every doctor, those are in some instances, some cases. So they've been, seeking alternative methods. And as I said, in my experience, I had very highly competent midwives who did the care. I was so closely monitored and so well taken care of. And I got to the point where I had no doubts, no questions. There was contingency plans set in place, if we needed to do a transfer to the hospital. They're very highly prepared and trained for, all kinds of scenarios. And then once, if needed to be transferred to the physicians, to the OBs, they do have those relationships in the hospital. So, that's really all you can hope for, is that, nothing goes wrong. And if it were to go wrong, then you have another plan set in place for that. But again, it's all about, right, the well-being of mom and baby. And if, hospitals are implementing ways so that women can feel that they are having their respected, births that they want to have, and they're healthy and their babies are healthy and happy, then I think we're headed in the right direction.
No, I do agree, and I think part of, our learning is soliciting feedback from our patients when they leave the hospital, and we want to know, how did we do? Where did we go wrong? How do you think we can do better? And we also know that this is a family experience, and so we want to include families in the birth experience, and so we want to know how can we make it better and not medicalize something
Mhm.
that's a natural process. And I know that, where I work, we've implemented, visiting hours where in the past, children weren't allowed. Now we have children in the hospital after moms deliver to come in and, just say hi and be there and to experience, this new addition to the family. And you might think, wow, why didn't you think of that before? But it's just wasn't something that we thought about until we got feedback from our patients. And,
Mhm.
like I said, I work in a field where it's a high risk OB, and sometimes patients experience complications during the pregnancy that require hospitalization during the pregnancy. And they could be in the hospital for weeks sometimes before they deliver. And even in those instances, we make sure that their family members, their children, they can come and they can visit so that they don't feel like they're disconnected from whatever is happening at home. So we know that that has a huge impact about, with someone's well-being and how they feel cared for in the hospital.
Yes, that's so important. Dawnette, thank you so much for your time and for sharing with us your knowledge and your experience. I know that you are very busy, so I will let you go. But again, I appreciate your time and providing this space for us, this to listen to, someone who's in the field every day, seeing high risk patients. But also, thank you for listening to me, who has done an alternative way of doing my life with my kids. So anyway, thank you so much.
Thank you so much for having me, and
Mhm.
it was wonderful, having this conversation and this discussion, and it could be longer, so let's continue this conversation because there are more topics that we can delve into.
For sure. I think there's a surplus of topics we could have even touched today, but I wanted to, keep keep the time considerate, your time, my time, but especially yours. And if you come back on the show, we'll definitely touch more topics.
No, absolutely. Thank you.
Thank you.
Alrighty, take care.
You too.
Bye-bye.
Gracias, and thank you for listening to this episode of the Unapparent Podcast. If you enjoyed this episode, be sure to subscribe as we release a new episode at least every month with an exciting new guest. Be sure to also follow us on Instagram for all the unapparent content you never